In today's lecture, we're talking about documentation in ophthalmology. Whether you're a patient that wants to understand what the letters and abbreviations mean in our notes, or whether you're a student or technologist entering the field and want to know about how we scribe and document, this lecture, we go over it all. So everything's organized, and that's what's nice about it, and that's why whenever we look at our examination, we go through an entire checklist. It's always the same way every single time. And doing it the same way every time means nothing gets skipped or missed. Just like a pilot that's ready to take off, there's a checklist of things they look for. What's our fuel gauge? What's our landing gear? Everything gets checked before takeoff. So same thing for this. For every examination, we go through a normal checklist, and that checklist ensures that the entire eye anatomy has been checked completely. So in the upper right, I'm going to put just a diagram of the eye, and then as we go along, you'll see where each part fits through it. So like normal, we draw our side view of the eye. Over here. And we'll talk about each section as we go. First part, whenever you see an ophthalmology note, there is going to be the history part of it. And this is carryover for anything in healthcare actually. There's going to be a history. Why is the patient there? And so the very first part of any note has nothing to do with an examination. It has everything to do with the history taking. So you will see first off the CEC, or the chief complaint. Whether you go to urgent care, the ER, or a family doctor, or an ophthalmologist, the chief complaint, that is the primary reason why that person is there. Are they there because they sprained their ankle? Are they there because they have blurry vision? So that's the chief complaint. I'm going to gloss over some of the history part of it because we'll get to the nuts and bolts of the examination, and that's the primary part. Next part, you will see something called HPI, that stands for History of the Present Illness. This dives into more of the details about that chief complaint. How long have they had it? If you remember from our previous lecture, we talked about OPQRST, that's the mnemonic, OPQRST. The quality, the radiation, the severity, the timing. What does all of that have to do with the pain they have in their eye? So that fleshes out the details of the onset, the timing, the quality. Are there radiations to the pain? What are the associations? What are the alleviating factors? That all goes in the HPI. Next, you will go into something called the past medical history. We'll just abbreviate it PMH. Some people will write something like PSH. That stands for past surgical history. Some people will write something like past ocular history, so POH. Did they have LASIK? Did they have cataract surgery? All that would go into this past medical portion of the examination. All these abbreviations, that you know what these mean on the notes. Usually you'll see a section in the note on the top where it's medications. You'll see something for allergy. You'll see something for review of systems. So this all goes into that past medical HPI section of every note. That is just a quick 2-minute rundown of that because I think the majority of this we want to talk about the eye part. But I just mentioned that up at the front so you kind of know that's the history taking. That's usually the intake nurse or the ophthalmic tech will take that part of the history. It'll usually be in the note on the top. And usually a lot of that's just data that's inputted by the patient when they check in on a registration sheet or by an intake nurse or tech. Questions on any of that before we move on to the next part? Okay, now the best part. This is where we talk about our portion of it. Oh, one more thing, examination. This we sometimes gloss over but there's something called the GA, or the general appearance. This would be something like, are they oriented? What is their mood? What is their affect? So general appearance, this is what you see right when you walk in the room, even as you begin to take your history, even as you jump in the room and bring them into the room. What do they look like? Are they in a wheelchair? Are they delirious? Are they unconscious? You'll see an abbreviation usually here, A and O times 3, something like that. That means they're alert and oriented to time, place, person. So now the best part of the exam, we're going to start with what we're here to talk about, which is the eye part of it. And examination for the eye always goes in a particular order. And if you look at an eye, this is kind of the side view, we'll do the front view. We always go in a specific order, starting from out to in. From out to in. So the first part, when you look at an eye from side view, the first part actually isn't the eye, it's the structures around it, and we call it the adnexa. Adnexa would mean, do they have swollen lymph nodes? Let's say they have a conjunctivitis and we're checking for swollen lymph nodes. Let's say they have a rash around the cheek and forehead. Let's say they have shingles. So the adnexa is where you'll document a lot of those findings, usually as it pertains to skin, usually as it pertains to trauma, let's say lacerations, or rashes like in shingles. So adnexa, actually in a cataract practice, we really don't comment on the adnexa, because in a cataract practice, the adnexa really isn't our primary focus. But adnexa should go on that, because as we start our exam, we want to know what's outside the eye as well, in the adjacent structures. So a lot of times for adnexa, that will be commented on in great detail in an oculoplastic examination note. As we work our way closer, we get to the eyelid, eyelashes, and usually in notes that will be written down like this, L and L. Eyelids, eyelashes. In this section, at least for what we do, you will find comments like, is there debris there? What do the meibomian glands look like? Do the meibomian glands show inspissation? Is there meibomian glandular disease? Sometimes you'll see it commented like MGD. Is there dermatoclasis? Is there ptosis? Sometimes we'll comment on how wide the eye is open, and there's something called the palpebral fissure. This is the measurement from the top to the bottom of the eyelid, the palpebral fissure, PF. In this section, you might see something like the distance from the pupil to the top of the eyelid. This is the MRD1. So in a cataract practice, we're not putting too much detail on the eyelid as compared to maybe an oculoplastic specialty or someone who's interested in doing blepharoplasty and eyelid work. They're going to comment on everything. The ectropion, are there lashes gone, is there matarosis? But the lids and lashes are important even for a cataract practice, because a large part of an evaluation for cataract patients is how much ocular surface disease do they have, and a lot of that comes from an examination of the eyelid. So as we work closer in, what's the next thing? We're going to be looking at the conjunctiva. That's the white part of the eye, and often you'll see it written just with the big C. C stands for conjunctiva. This is the section you'll see words like hyperemia, or injection, it kind of means the same thing. That means how much are the blood vessels injected in red? Is there chemosis or swelling? Is there hemorrhage, subconjunctival hemorrhage? Is there a laceration? Is there a pincecula? All that will go in the conjunctival section. So as we work our way deeper, we're getting to now the cornea. That's this part of the eye. The cornea. Now look, we already used C, so we're not going to use C again. We already used that letter. The next letter for cornea, we're going to just label it a K. On our corneal notes, you want to look specifically, is there guttata, is there fuchs corneal dystrophy? Because that's an important finding, especially if we're doing a cataract evaluation. Is there any epithelial basement membrane dystrophy? Are there fingerprint lines? That'll also be very important to look at. Is there a history of LASIK? All this goes onto the cornea. These are all issues that we'll document on the cornea. Is there swelling, edema? Is there staining with fluorescein? Do we have an abrasion? Are they wearing their contact lens on top of the cornea before you do your exam? That's the cornea section. Questions on that part? Okay. As we go a little deeper, now we get to the anterior chamber, or easily abbreviated AC, anterior chamber. I usually break this down into two questions. Question number one, how deep is the chamber? And the reason why that's important, if the chamber is not deep, that means it's shallow or narrow. And if there's a narrow angle, you can't dilate unless you make sure that they've had an iridotomy. And you also want to evaluate, which is the next question, is there anything inside the chamber that we need to document? This would be inflammation. This is like your cell and flare, such as after cataract surgery. What's the grading of cell and flare? Now in all these, when we look at ophthalmology, it's interesting, by convention, we don't, sometimes people ask, well, how bad is it on a scale of 1 to 10? We don't, by convention in ophthalmology, we use a 1 to 4 scale. Interestingly enough, where we have mild, a little bit more moderate, and then severe would be stage 4. So in a lot of ophthalmology notes, we're going to grade it on a scale of 1 to 4 just by convention. The cell and flare will usually have a value to it between 1 to 4. 4 meaning the worst, 1 meaning not so bad, and sometimes you can barely even tell there's anything there, and we might write something like trace. So trace 1, 2, 3, 4, and that is your only options. So a lot of times you'll see, okay, there's cell and flare, how much? Well, let's say it's 2 plus. And then when they come back after their post-op, a week or two later, let's say now it's barely there, it's trace amount, or there's none, maybe there's no cell flare. If there's no cell and flare, then we're going to call that quiet or clear. So if you see the word quiet, then you know there's no cell or flare. It kind of means the same thing, whether you put no cell or flare or whether you write quiet, it means the same thing. Okay, as we go a little deeper here, we're going to get to the iris, right? That's the next spot. And in our key, we're going to just say I. I for iris. This really not too much happens here unless there's severe pathology. You'll see things like synechia. This word means there's scarring. You might see chorectopia. This means it's not centered. You might see transillumination iris defects, TID, transillumination iris defects. That means there may have been a history of trauma, or they may have some particular disease such as pigment dispersion. One more thing that we'll talk about later on a different lecture is NVI. This is neovascularization of the iris. So we'll be talking a little bit more about that on the diabetic lecture. So that rounds out the front. We're going to go now to the best part, which is the lens right here. So the lens is going to be RL, and every description here has to do with either the status of the lens, which might be cataract, or the status of a false lens or pseudophakic lens. If it's pseudophakic, you'll usually see a word like IOL, that means intraocular lens, or more specifically is posterior chamber intraocular lens. That is probably the most common word you'll see in a lot of notes for people that are 75 and older. They probably have already had cataract surgery by that time, and you'll see something like that written in their chart. In our notes, because we do a lot of second opinions, I will often do a lot more detail, like where are the haptics oriented, is there optic capture of the lens, is it a three-piece lens, is it a toric lens? A lot more detail I will put around that, but the main thing is there a lens there or not? If you remember, what wraps around the whole lens complex is the capsule. So we'll often in the lens section comment on the capsule, or the PC, posterior capsule. If you remember, after cataract surgery, a lot of people develop a posterior capsule opacity, or PCO. If you haven't already, there is a video we did put up recently about the YAG laser we do for that. So posterior capsule opacity is a very common issue that happens after cataract surgery, very easily addressed with a laser. Once again, on the PCO, we'll sometimes comment on how bad it is. Is it trace amount? Is it level 1, 1+? Is it 2, 3? A really bad posterior capsule opacity is like a 4+ PCO. The patients can't see the thing. Most people don't wait until it gets that bad. Most people will come in when it's maybe an early, maybe stage 1 PCO, and we easily correct it. And then finally, we'll talk a little bit about the cataract. We're going to expand on this more because there's more to talk about on the lens. So if they have not yet had cataract, you're going to see a lot more detail, especially in our notes, because we talk a lot about cataract and the details, because the type of cataract determines sometimes our surgical approach and how we prepare for surgery. The most common type of cataract, well, let's say they do have cataract, so let's write that part down. The most common type you'll see is nuclear sclerotic. This is your typical nuclear age-type cataract, and we will grade it on the same scale, 1 to 4. It might be 1+, it might be 2+. Let's say it's in between stage 2 and 3, then it might be a grade 2 to 3. The next common type of cataract you might see written down is CS. That stands for cortical spoke. In these cataracts, you'll see these spoke-like projections that start in the periphery and extend centrally. We'll also give these a grade scale, maybe 1 to 4 again. You might see a phrase like PSC. That stands for posterior subcapsular. Posterior subcapsular. This will usually be maybe a patient with diabetes or a younger patient that has a more aggressive type cataract. And we look for this term, you might see this too, anterior subcapsular, ASC. So these are some of the abbreviations when you see the note, regardless of whether it's NSC, CS, PSC, ASC, it still means cataract. So when you go to a cataract practice, they're going to maybe put a lot more detail about the type of cataract, the size, the grading, and that's the part that we always look at. Finally, the last part, on the anterior, this is the slit lamp examination. This would round out the last part that we can look at the front of the eye, or this anterior part of the eye. The last part we can see with the slit lamp without using a lens is the anterior vitreous. Sometimes you'll see that commented here at the front. We are looking for things like tobacco dust or the Schaefer sign or pigment in the anterior vitreous. So there's a little imaginary line that goes right through the front of the eye here. This is the anterior portion of the exam, and then this is the posterior section of the exam. So everything from this line forward we can look at with the slit lamp without using a lens, but everything at the back of the eye we have to use a lens, another lens like a 90 diopter or a 78 diopter to see the rest. Questions on any of that? We're going to take a little pause. Okay, pause time. So the next portion we're going to talk about the posterior examination, and for the posterior we're going to, same thing, we work out to in or we go in a specific order. So I think the best way is to kind of diagram our schematic. Let's say we're looking directly at the retina and the posterior part of the eye. So as we look through this, the next stage here would be the vitreous. That's right here. So that would be in our next phase. That's the dilated fundoscopic examination. We are going to first look at the vitreous. Or you can just put V for short. This is where we're going to look for problems like PVD, posterior vitreous detachment. We're looking for vitreous hemorrhage. Is there vitritis? But typically in your general examination, the main thing is there a vitreous detachment or not. A common word you'll see associated with this is floater. Some people document it as like a Weiss ring. It all means generally the same thing. It means there's something or a floater or opacity in the vitreous cavity. So as we go a little bit deeper into our schematic checklist, the next thing is here, the optic nerve. So you will see that usually optic nerve or optic nerve head. Mainly two broad categories that we look at on the nerve, and this is kind of similar how we looked at the chamber. It was, well, is it deep and what's in it? So for the nerve, first thing we look at is what does it look like, and that will mean is it sharp or is it edematous? Hopefully it's sharp. If it's swollen, then that's a problem. That means they have a optic neuropathy or some type of issue happening there. We comment on the color. Is it pink? Is it healthy looking, or is it pallorous? And if it is pallorous, is it grade 1, 2, 3, 4? If it's swollen, how bad is it swollen? Grade 1, 2, 3, 4? And then, so this is the appearance. This is the first part. And the second part we look at, which is the cup to disc ratio. Sometimes you'll see it written as CDR, or it means the same thing. So what we're doing with this is we're physically gauging the size of the central cup compared to the overall size of the nerve itself. So let's say we do a zoom in on that optic nerve, and you will see the blood vessels kind of curve around the edge of that nerve. We are physically measuring the total length of the top to the bottom of that nerve, and then we're measuring the total length of the center optic cup here to here, and we get a ratio, and that ratio can be anywhere from 0.1 to 0.9. So you'll see numbers like cup to disc is 0.1, or cup to disc is 0.2, 3, 4, 5, all the way up to maybe 0.9. Unless it's really bad, 0.99. That means we don't really see much of the cup, it's the whole thing. That is the cup to disc ratio. Really important to document that. The general rule of thumb is anything 0.5 and greater is risk for glaucoma. So keep that in mind. Generally speaking, you will see a 0.2 or 0.3 in a normal healthy eye written down here. If you're looking at a note and you see someone write down 0.9, then you have to ask yourself, well, if the cup to disc is 0.9, they probably have glaucoma or some type of optic neuropathy. If you write down 0.2, then you have to say, well, that's probably pretty good. So as we go a little bit further, we're going to work our way further in. Next thing is the macula. So we'll just say that as M, or you might even write it out, macula. When we do our macula examination, we're looking for, what does the foveal reflex look like? Is there a crisp reflex, or is it lost? Is it blunted? Is it swollen? So that'll be like in macular edema, M.E. That'll be like cystoid macular edema or diabetic macular edema. If you see ME in the macula, that's not a good thing. They probably do have some loss of vision. Is there other terms you've seen there before? Yes, you might have seen words like AMD or macular degeneration. There will be drusen here that were commented on. And then one last section on the dilated fundoscopic examination is the periphery. This is where we're going to comment for things like horseshoe tears, retinal breaks, and retinal detachments. Hopefully none of those are there. So that should round out your whole posterior examination. Before we conclude the documentation portion, I'm going to go over one other part of the exam that we document, and that's the vital signs. So let me go ahead and erase the board, and we'll move on to that section. Okay. All right, so the next section, we're going to talk about the vital signs. This happens even before, this happens in between the examination and the history taking. Just like if you were to go to an urgent care, what happens first? Well, the nurse comes and she takes, or he takes, your vital signs, like what is your blood pressure, what's your temperature, what's your heart rate, what's your respiratory rate. Vital signs in ophthalmology are also taken by a tech or a nurse, and let's talk about that, the vitals of ophthalmology. A really fun topic because for every intake, this is where it comes from. So, number one, what's the Number one thing that you test every eye examination.
Pressure.
There's one. You got one.
Visual acuity.
Okay, there. Let's do that first. Visual acuity. This is probably the most important thing. Sometimes in ophthalmology we joke about it. They'll call and they'll say, yeah, we'll get a call from a consult. They'll say, yeah, the patient's pressure or the patient's vision is blurry. And we'll say, what is the vision? Well, this is an actual, maybe more, it is subjective in some sense, but it's a little more objective than just saying it's blurry. Because you might have someone that comes in and they're 20/20, but they say it's blurry. Or you might have someone come in and they're 2200 and it's blurry. So this gives a maybe more exact measurement of vision. And by convention, when we write visual acuity, we always, in handwritten notes, it's not so important in like an electronic medical record, but in handwritten notes, the right will always go above the left. Historically, right-handed people are thought of as better than left-handed people. And for that same, I don't know, just by convention, OD-OS. So OD, that stands for oculus or oculi dextum or dexterum. And OS, that stands for oculi sinister, because left-handed people are sinister. From the Latin root, meaning to the left. And then if you write, so let's say you check the vision for both eyes, OU, U stands for uterque or uterque. That's also from the Latin, from the both or both eyes, just by convention. So by convention, even when you go to our deeper examination, if you, for instance, we're talking about the eyelids and eyelashes, well, sometimes say it's normal on the right and maybe there's ectropion on the left. I don't even have to write left eye. We know that's written on the bottom and there's an arrow, so that's shorthand for right eye is good, left eye has ectropion. So just by convention, right always goes on top, OD, OS. You will see other terminology here like SC, without correction, sine or sin correctione. You will see words like CC, con correctione. So if you have any Latin or French or Spanish, C, that means con or with. That's where this portion goes. You already mentioned pressure, so let's write that. Now I don't usually write pressure with the big P, but you could. Normally we write it with a T, because normally we're measuring pressure by tonometry. And next to the T, you will see a smaller abbreviation. Usually, in a lot of offices, they'll have a tonal pen, so you see a TP, tonal little p, and then you'll write your numbers. Let's say it was 16, 15, and you'll usually document the timeline. Let's say it was 9:36 in the morning when you measured that. Let's say you used a Goldman applanator, so you'll see a T capital A. That means you applanated by hand, and you'll write the same numbers. You verified it, it was the same, and it took you 10 minutes to do that because it was hard. So there you go, 9:40 a.m. Sometimes you'll see non-contact tonometry. It'll be NCT on the bottom. You'll see different forms, but usually the T stands for tonometry. What other vital signs as a tech are you taking? This is the vitals section. Pressure, vision.
The lamp.
Pupil, great. That's where we write P. So pupil is where you're going to look for, afferent pupil defects. We're going to be looking to see, do they constrict with light? What is the pupil size before we dilate? So that's the pupillary examination. So now you've got 3 out of the 5. What's left?
The angles again with the light, or no?
That would be more like in the slit lamp examination. But of course, when you do your swinging flashlight, you can easily test that too.
Peripheral vision.
Correct. Peripheral vision. This is going to be our screen to look for confrontational visual field testing. So we're looking for patients who might have a retinal detachment or stroke. Is there a superior field cut? Is there a temporal field cut? If you see a temporal field cut for both eyes that matches, you worry, oh no, is this a stroke patient that just walked into our office? So confrontational fields, very important whether you work in an ER or whether you work in an eye office. Field testing is very important. It's not too hard to do if, with good practice and a cooperative patient. One more vital sign here. Can you think of it? So you have 4 out of the 5. It usually happens right around when you're doing confrontation. It actually can happen really quick. And this is the EOM's extraocular motility exam. This is where you'll see me write things like alternate cover testing. ACT, you'll see me document, are the eyes ortho or are they crossed? Are they esotropic? Are they exotropic? Are they esophoric? You'll see it documented something like that with the parentheses, exophoric. And then what are the versions? Do they have, for instance, a 6 palsy? Limitation in abduction. So that will round out your vital signs. 1, 2, 3, 4, 5. So on your examination, a complete examination, you'll have your history, which we talked about, your past medical, your view systems. You're going to have your vital signs, and then you finish off with your anterior posterior examination. Finally, in the lower section of every note, you will then see the impression and plan section, IP, or assessment and plan is another way people document that. This just says what is the diagnosis and what is our recommendations. We want to prescribe a medicine, we want to say you need laser or surgery, or we want to say you're fine, get your glasses, and we'll see you on your regular schedule then. So that will be the whole note. Questions on anything on that? So, super broad overview. Hopefully that helps. If you ever look at a note now, I want you to start to look at how is it organized? Are all the points checked off? Was anything skipped? Did we comment on every section? Because this is just like a pilot ready to take off. Every single section in a complete evaluation is checked off. That's how we're thorough. That's how we know we've checked every single section. And as you see eye doctors look at an examination, we check both eyes and we go through the same checklist every time. If you find this lecture useful and are looking towards more information about other general topics in ophthalmology, whether you're a student learning about it or a technologist, then click on this playlist where we go over more lectures and topics of ophthalmology.